Hello and welcome to today's webinar, Building Member Trust and Loyalty Through Community-Based Social Support Groups. Before we get started, I'd like to review a few housekeeping details. Today's webinar is being recorded and an online archive of today's event will be available within 1 to 2 business days. If you have trouble seeing the slides at any time during the presentation, please press F5 to refresh your screen on a PC or Command R if you're using a Mac. You may ask a question at any time during the presentation by typing your question into the Q&A box located on the right side of your screen and pressing Enter. And finally, I'd like to remind you of AHIP's antitrust statement located in the link just below the slide viewer. We will, as always, comply with that statement. Among other things, the antitrust statement prohibits us from discussing competitively sensitive information. We're very fortunate to have with us today Dr. Claude Pinnock, Chief Medical Officer, and Mr. Bill Friedman, Vice President of Payer Engagement, both from Wider Circle. At this time, I would like to turn the floor over to our speakers. Welcome.
Thank you very much.
Thank you
Welcome,
so
everybody.
much.
We really appreciate you joining us today. Let me make a quick introduction here. I'm Bill Friedman, as you just heard, Vice President of Payer and Provider Engagement. My work here at Wider Circle is really focused on our engagement with health plans across the country from north to south. My team is responsible for all of those relationships. I come from the payer world, spent many years on the payer side, leading sales teams in both the commercial space as well as the government program space. And the last 8 or 9 years, I've been helping companies like Wider Circle engage with health plans, helping them deliver their care management, social determinants of health, and member experience solutions. So very excited to be here today, and even more excited to be joined by my esteemed colleague, Dr. Claude Pinnock.
Thank you so much, Bill, and good morning or good afternoon to folks attending wherever you may be. I'm Claude, Chief Medical Officer of Wider Circle, and here at the company, I lead our overall research and healthcare strategy, in addition to supporting business development and doing events like this, which are one of my favorite parts of the job. You'll hear from me in a little while, but I'm going to hand things over to Bill to begin with. So, Bill, over to you.
Thank you, Claude. Really appreciate it, and very excited today to give you a little bit of a download on who we are, what we do, how we do it, what makes our solution unique, what makes it so really helpful to health plans as they engage with members. Hard to reach members, easy to reach members. It's about building community for your members. We'll talk about how we do that today. A little bit about the company itself. We were founded in 2015, going on 9 years. We are a public benefit corporation, and our flagship Connect for Life product is available currently in 7 languages. It's available in thousands and thousands of communities across the country. One of the really nice things about Wider Circle is that we are not a pure technology solution. We are a people-first company. We are about building relationships, building bridges, and leveraging that community that we create to address social determinants of health, to address barriers to healthcare, to address HEDIS measures and gaps in care. And we'll dive pretty deeply today into how we go about doing that. We're about 400 employees across the country, but more importantly, we're about thousands of peer ambassadors. Those peer ambassadors are your members who become brand ambassadors for you. They are out there in the community, talking to their friends, talking to their neighbors, more importantly, helping their friends and helping their neighbors. We'll show you how we create that in a few minutes. And again, we are all about engagement with a purpose to improve quality measures, health outcomes, and that member experience. You can see on the bottom of your screen some of the companies that have chosen to do business with us. A little bit about the concept of Wider Circle and why it's so impactful. I come from the health plan world, again, as I said. As a health plan employee, I know what it's like to make thousands, if not millions, of phone calls a year, millions of outreaches, whether they be by text, a notification in your member portal, a call center outreaching. Hopefully, we're reaching members and asking them to do this or do that, trying to move the needle, change behaviors, get members to be compliant with certain health plan needs and certain things that will, of course, benefit them. The challenge is all of those channels have, somewhat minimal efficacy. What Wider Circle knows and what we have discovered over the past 8 or 9 years is that although members might not trust it when their health plan picks up the phone to call them, and that might not move them to action. Sometimes even their provider calling them doesn't move them to action. What we've discovered is that members trust what their friends and their family and their social circle says. So if their friend or their family member says, "Hey, Bill, you're 50, you should go get your colonoscopy," there's a higher likelihood of that message getting through than if the health plan calls and leaves a voice message about it. So what we try and do is build those type of bridges hyper-locally in communities across the country, connect members with members, facilitate those those conversations about proper utilization, when to go to the ED, when not to go to the ED, why it's important to have a preventative care screening or to get a vaccine or to get your annual wellness. All of that leads to lower cost, higher engagement, and greater member retention.
The mission of Wider Circle is to connect neighbors for better health.
Our well-being, our happiness, everything is just linked to our community and to our neighborhood.
Everyone needs somebody to lean on, and that's really what joining Wider Circle is an invitation to be part of.
We read over 600 publications that looked at the science. Being together in a community is critical to our health.
Before I joined Wider Circle, I was home every day, just about, doing not much of anything. Then we started doing activities, and then I got myself moving, and I got off the couch. We just had a great time.
We found some good friends. Being in the group is just, all the time it's happy. We have a lot of fun together.
It gives me something to do, get up, do yoga, and, get the bones working. It's pretty good. I like that.
Neighborhoods in which we've been operating for a while look different. Neighbors know one another more, say good morning to one another. If there's a senior living on the block, he's not alone on Thanksgiving. People knock on his door, bring in turkey, say, "How are you?"
I got sick, and I got sick with COVID. And my entire family in December. Members left food outside my house, and it was the most wonderful 2 weeks that we had because the food was delicious. That was an amazing experience that we had. How much love there is in the community now, and I feel the same way for them.
A cardiologist came to speak to us, an ophthalmologist came to speak to us. We even had a meeting on estate planning. So you're learning and having fun at the same time.
No le damos chance a la vejez ni a la depresión, porque vamos combatiendo eso con la alegría de compartir todo.
I see members' faces smiling, getting healthier, socializing, and that brings me happiness.
If you have somebody that's kind of hesitant to join, basically I tell them, just come to a couple of events and just see how much fun we have.
Nos mantenemos jóvenes, always happy, always young.
All right. So whether your members are Medicare or D-SNP members like you saw in that video, or Medicaid members, we have a solution for them. And, what I really like to do is tell you this from kind of the member's perspective, right? It doesn't mean so much for me, but, who you see on your screen here, Delilah, well, Delilah had some tremendous challenges. She started attending Wider Circle both virtually online as well as our physical events. But then she underwent a couple of hip surgeries, physical therapy. She lost some mobility. She felt isolated. She gained a lot of weight. And then she started attending Wider Circle again. And because of the community around her, because of those new friends that she made, because of those relationships, people that live on her block that shop at the same supermarket, she was able to get out, get working again, get motivated, lost some weight. She's happier. She no longer feels that she's isolated. She's now part of a caring community. So again, whether it be a Medicaid member, a D-SNP member, a Medicare Advantage member, that is the type of uplifting story that is just so common at our company. And I could have picked one of literally thousands of member stories to plug into this presentation today. So how does all of this good stuff play out? How does it work? Right? I've mentioned we create community for members. Very often it starts by identifying and addressing social drivers of health, barriers, and connecting members to local resources. Probably more importantly, we then feed that data back to the health plan. We help members build these support systems around them. It's one thing to be available to that member for the hour a week or the hour a month they might spend with us virtually or physically in a meeting, having lunch with us. The goal of Wider Circle is to build those relationships so when that member goes home and it's a senior that needs a light bulb changed, or it's a Medicaid member that needs a ride to the doctor's office, or they have some other challenge where they need community to uplift them, to help them, to lean on, they have those relationships in place. We educate members about proper utilization as part of our curriculum, preventative care, and various chronic conditions. We get members out of the house. We get them up. We get them active. We get them engaging. And that's really a very important part of what we do. How does this all start? Well, it starts hyper locally in the communities we work with our local community staff. We hire folks as facilitators in the communities we work who are immersed in the local culture, speak the local language, understand local customs, shop in the same supermarkets, drugstores, go to the same houses of worship as the membership they're serving, regardless of the line of business. We bring folks into these meetings who are likely to form friendships regardless of being in Wider Circle. So we get eligibility, we get claims, we get all that data, we build these cohorts of opportunity, and we bring members in, by the way, with our own call center and our own direct mail. So we are not leveraging health plan resources really for almost any of the functionality that I'm going to talk about today. We bring folks in for a 4 to 6 week onboarding program that is all about engagement. It's all about fun. It's all about building connections and building bridges between members. We do not call members up or send them a postcard and say, hey, come to Wider Circle and learn why it's important to get a vaccine or a preventative care screening. We reach out to them to engage, only about fun. Over time, as we build trust in that group, and as that group learns to trust us, then we build the healthcare narrative into that program. I mentioned ambassadors before. Once folks are in our program and they graduate and they become members of Wider Circle, there are those members that will want more purpose. They will want a mission. They will want their voice heard. And we give those people that opportunity. So they go through a little training program, they get a certificate, they get a diploma, and they become Wider Circle, and therefore your health plan's ambassadors in the community, working with other members, talking with other members, and helping other members engage more deeply with their health plan and with their health care. It all starts with data. So we are obtaining eligibility and claims from our health plan partners. We bring that into our proprietary algorithm. And again, we build these cohorts based on demographics, age, sex, location, but also based on morbidity and challenges and gaps in care. So we're bringing folks in proactively who might have not seen a PCP in the last 12 months, so we can educate them about that. Might not have their vaccines, might not have their preventative care, helping with HEDIS measures and helping to build a healthier community. We have technology that we leverage to manage this whole process. As you can imagine, with thousands of meetings, there are lots of logistics to arrange. So we have a proprietary case management platform that helps us arrange meetings, arrange the invites, record results, and probably most importantly, from your perspective, deliver those results back to the health plan. And we do report on approximately 130 different data points in the course of our work and send that data back to you. We have a member mobile application that members leverage to stay current with our program. They can look at the calendar, see the meetings that are available, the upcoming ones that are virtual, and the ones that are actually physically and on site and in their community, what's closest to them. They can engage with their facilitator and engage with their peer ambassadors. They can communicate with each other without having to give up any personal information. With the proper permissions, they can post pictures of events. And again, really just a social media application for Wider Circle, just one more way to keep folks connected and keep them engaged. So just a little recap of this member journey. We build these cohorts. We invite folks in, direct mail, telephonically. We bring them into this onboarding process. We talk about fun. We have them meet their friends. We create bonds. We create community. And then in that process, we meet with our health plan partners on a monthly basis to discuss what your priorities are. We also build those priorities into our contract, into our program. It is a super templated approach. It's a repeatable approach. And again, it's one done that really does not leverage too many health plan assets. You can see here a snapshot of what a typical March might look like. There is a monthly theme, in this case, National Nutrition Month, and then every week has a theme, whether it be the virtual chapter or it be the in-person chapter. And again, there's multiple meetings, there's multiple ways members can engage. Maybe some weeks they can come out to a physical meeting, maybe some weeks they're unable to come out to a physical meeting. They can join by phone. Maybe somebody lives in a more rural area where getting out to a physical meeting is more difficult, so they might be more likely to engage remotely. What we also find is that in more rural areas, we get even higher participation in this program because there aren't that many distractions as there are in a more urban or suburban setting. So although we might have more people in general join remotely, when we do host events, those events tend to be bigger and members tend to get more involved, and they tend to come from farther away because they just don't have as many opportunities to engage with their neighbors in more rural areas. So it is all about building this circle of trust. This circle of trust that we control the outreach, again, direct mail, phone, assessing members for SDOH gaps and connecting them to those services on the left side of your screen, reporting that information back to the plan. But again, leveraging those plans' priorities, whether it be HEDIS, whether it be STARS, whether it be various gaps in care, whether it be other individual opportunities to bring services that you have, other benefits that you have to these meetings. For instance, if you had a stop smoking program or a gym membership, that can become part of the curriculum. If we're in the fall, obviously most of you are going to be worried about maybe redetermination or AEP. So we will make that the topic of discussion. We do a ton of work helping to retain members. We're going to record all these transactions and we're going to send it back to you. We're going to create pathways with your member services team, with your community health workers, if you have them, with your case management team, because they will come across members who could benefit from the community that Wider Circle can create. And we will come across members in the course of our work that need deeper engagement from the plan side or more clinically deeper engagement, and we will connect them back to your case management teams. And with that, I'm going to pass the microphone over to Claude to talk to you a little bit about social needs and a little bit about the evidence that really is so important to what we do. Rigor and the rigor of our data is really a vital part of what we do, delivering that ROI back to the plan. So Claude, please pass it to you.
Thanks, Bill. So as Bill was mentioning, one of the key things our program works to address is a lot of the social drivers of health: food, housing, transport. And one of the things we've found a real sweet spot for with our program is actually in addressing these for our dual eligible members. As a trust building org that's tackling social needs, you can clearly see the link here. Duals are more likely to be food insecure, have limited health literacy, a lack of access to transport, lower education, and just lower resources in general to get good healthcare access. And this matters because these things affect between 30 to 80% of health outcomes. So what you're going to see shortly in some of the results I'm going to share over the next slides is how we perform in those dual populations. But before I get to that, I want to just briefly touch on something around engagement, because this often comes up, and I think it's really important to explain our engagement funnel. One of the unique things we're able to do through our claims data is ID specific cohorts of opportunity that are perfect for our program. And what we do is leverage inputs from around 32 different factors of risk, health patterns to ID specific cohorts of members we think would be most likely to benefit from Wider Circle and where we believe we can deliver a strong return on investment. Whether that's members with high emergency department utilization for non-emergent conditions, or members with chronic diseases who don't have a registered PCP. And then using our multimodal outreach techniques that Bill mentioned, we target the whole of that cohort of focus. And what that leads to is around a 26% engagement and 20% overall enrolled in the program from these cohorts. And the other thing I'll just mention here before we move on to some more granular results is what I've just articulated is also strategy one. We engage with these population of focus cohorts, but we also engage with the entire population of focus as well, the whole membership. But this gives you sort of hopefully a sense of the overall funnel amongst our different personas and where some of the results you're about to see are coming from. So Bill, if you will, on to the next slide. The first thing I want to touch on here is at the macro level, we've just had our best ever year. So what I really want you to take away from this is this can often seem like a bit of a kumbaya grassroots kind of organization and program, but we're kumbaya meets calculators. We take that grassroots approach, but operationalize it at scale. And in the last year alone, we've had over 11,000 in-person events, over 500,000 member connections from an eligible pool of well over 1 million. We've doubled in size, and we typically engage with about 22% of the members we target. So what does that mean in terms of ROI? How does that kumbaya meet calculators, as I like to say? Well, the first thing it's worth doing is explaining in brief how we arrive at the results I'm about to show you, and so you have some confidence in them. We have this robust data architecture and claims that allow us not only to match members together, like I just talked about, But the other cool thing it allows for is for us to be able to conduct rigorous, scientifically sound studies that mimic actuarial studies. Our results are essentially uncovered through conducting what's called retrospective cohort studies. And what that means is from a historic time point, we follow individuals who have been exposed to the wider circle intervention and a similar control group over that same time period. And in order to ensure the participants in each arm are as similar to one another as possible, we use something called propensity matching. What we're doing is looking at the pre and post values across all of those members in the intervention and control group and calculating a difference of differences of those pre and post matches. And then the propensity matching is where we create member pairs where the members themselves are as identical as possible to one another, except for the fact that they have been exposed to wider circles. So similar baseline utilization, comorbidities, demographics. And that's what the difference of differences is actually calculated off of. We were so confident in our methodology here that we invited Milliman to conduct a review to assess the appropriateness of it for quantifying the impact. And we've linked the full report here, but essentially they found that the methods were both reasonable and appropriate and consistent with typical actuarial practices, which is essentially Milliman speak for we're doing the right thing methodologically. So we were really proud of that. So let's actually talk about some of the rubber hitting the road. On this next slide, we look at our DSNP and first year results. So using that methodology I just articulated in a massive national DSNP rollout, first thing we had was just great engagement nationally across the whole membership. And then we also derived 3 key sort of pockets of value across this membership. The first in member attrition, which we reduced by 1/3. The second in preferential utilization patterns for members in both inpatient and emergency department utilization. And then the third in risk adjustment value, which is unlocked through increased annual wellness visit and HRA completion rates. So really impressive results from our first year on a national DSNP plan. This next slide talks to a study we conducted in United Health Group members and Optum. So same methodology again, Medicare Advantage population here. And what you're seeing is favorable utilization patterns across the board in terms of PCP, ambulatory care versus inpatient settings. And in addition, those exposed to wider circle had better quality outcomes across the board. Things like annual wellness visits, advanced care planning, and medication reviews were all higher than in the control group. And finally, members were 50% less likely to voluntarily disenroll from the plan if they were wider circle participants. Because we had such a good relationship with this plan and Optum themselves, on the next slide, we were able to see sort of the actual dollar values derived here because we had a close relationship with their actuaries. Key findings here, roughly half the savings on retention, a quarter of from the utilization, and the rest on RAF on quality, with a total of about $140 per engaged member per month in savings. Moving on to another national Medicare plan. Again, same methodology. I sound like a broken record. What's different about this study is we actually conducted a wide-scale patient-reported outcome, or PROM, collection as part of the initiative of that pre and post data collection. What we used was a patient-reported outcome tool called the UCLA 3-item scale. And what that does is capture self-assessment of loneliness. And we also used the health-related quality of life tool PROM. And what the study showed using that methodology was a 65% improvement in loneliness. But that's quite hard to conceptualize. So what we also did with our partners was conduct a logistic regression to calculate the odds of going from being lonely to not lonely. And it's a bit of a tongue twister, but the punchline was that wider circle members were 3.8 times more likely to go from being lonely to not lonely. And this study is currently in peer review. Next study on the next slide is another DSNP one. This was with Health Plan of San Mateo. The punchlines here, just over a 25% reduction in PMPM spend and a 50% reduction in voluntary member attrition, both of which delivered great value for the plan. But the other thing worth mentioning, and the other key value creation here, is how 32% versus 21% in the control group transitioned to an aligned plan, which we know is better for members as well as better for the plan. On the next slide, this one's actually published in the Archives of Public Health. This is in a Medicaid population amongst African American members. Punchline here, showed $115 in cost savings and maintained or improved quality metrics such as access to preventative and ambulatory health. And again, this is an open access. You can search for that journal on PubMed and you'll find it and be able to read the full published reports. And now I believe my final study for today. The idea here, we call this Connect for New Life, if you will, is that we would group pregnant mums together by due date and by trimester. And that shared lived experience, mixing together multiparous mothers with first-time mothers, would create a really nice social dynamic. And we tailored the content around specific perinatal content. And this is, again, in peer review. The feasibility studies were great. We showed better engagement, high acceptability, and whilst our N was small because it takes 9 months for folks to come out, directionally we showed improvements in really important perinatal outcomes like C-section rates, low birth weight rates, and preeclampsia and eclampsia, all of which are significant cost drivers. So that's it on the sort of results side. Hopefully it's given you confidence that A, the methodology we use has been independently validated, and B, we have results across all the lines of business we work in, whether that's Medicaid, dual eligible, or Medicare Advantage members. And with that, I will pause and hand it back to Bill. Thank you so much.
Thank you, Claude. Appreciate that. Well, you've seen the evidence. But we go a little step further than that, and that's we put our money where our mouth is. So depending on the line of business and depending on the population, we build different SLAs into our contract, different performance incentive metrics that address some of the challenges that our plan partners have, and we put money at risk. And we, at the same time, put money at risk. We also can build a direct line of sight to the ROI through those performance metrics, so you know the value that you're getting for an investment in a program like Wider Circle, which truly, truly does pay for itself. So things like increases in annual wellness visits, increases in member retention, lower inpatient days, those are all sample metrics we could build into a contract. There are many other levers we can also pull as well. How to finance this in the Medicare world or in the Medicaid world? We are always a medical expense, so we are not part of the admin. We are a clinical expense. On the Medicare side, we could be in the bid, we could be a supplemental health education program, we could be a reward and incentive program, or we could also be a quality initiative. Either way works. I will say that this time of year, quality initiative comes up quite often in the Medicare and D-SNP space. Because really the best time of the year to employ a solution like ours is headed into the fall, where membership is going to be getting tons of mail. They're going to be getting tons of pressure to look at other plans. That is one of the work streams that we do so much work with, as you heard Claude mention about retention rates, 50% improvement, 36% improvement. We get members together in the fall. We tell them, don't even open your mail. Come see us. Come chat, we'll talk about what to do. We'll hold their hand. We'll, reassure them that their plan benefits really aren't changing regardless of what they heard. We'll walk them through any changes there are. And we will do a ton of work helping our plan partners hold on to their membership through AEP. So a lot of QIA work as we head into this time of year, as we head into the summer and hopefully launch in Q3. I mentioned earlier that our work does not require a lot of health plan resources or bandwidth. Our rollout process typically takes about 90 days. There's really only a few areas where we need deep collaboration with the health plan to move a project like this forward. One, we need claims and we need eligibility. We don't need an API. There's no big IT lift that needs to be created. We need claims and we need eligibility. There's other risk stratification data that you'd be willing to share. The more data we have, the better in building our cohorts. We create a marketing partnership. So with our templated approach, and there are templated marketing pieces, there is our mobile app, there are call scripts that need to be approved, but these are all built already. So it's really just about tweaking them to make sure that your brand is represented the way you want it represented according to your brand guidelines. So we work together to move that forward and get that approval. And then we're ready to launch. We're ready to go. Again, our program is in place already. The other area of continual cooperation is that we're going to meet again with our plan partners on a monthly basis to share results, to share those engagement numbers, to share those success stories, and most importantly, to understand what the health plan's particular priorities are at any particular time in the year. So we're making sure to build that into our curriculum to help move the needle for you. Just a few screenshots here. Again, very templated approach, whether it be marketing material. And again, we're doing the direct mail. It's our own wholly owned call center. We don't outsource and we don't send anything overseas. It's all done domestically. One of the really interesting things about our outreach that makes it really unique is, unlike the plan calling, we are a third party. So we get a lot of honesty in the sense that people are, willing to tell us things they're sometimes not willing to tell their health plan or their doctor. But more importantly, once the relationship is built, once they've come to one meeting or joined once virtually, they then have that relationship with that facilitator. And that facilitator is managing the outreach. So there's a direct connection. They know they're going to speak to the same person all the time. There's consistency to it. And that really helps engage a population that sometimes, especially in the Medicaid space, is not as trusting as we'd like. You can see some screenshots here of our member mobile app and call scripts. We are high trust certified, so security is never an issue. We take your data and we are, you can be certain that it is secure. We have a world-class NPS score, usually typically somewhere 80 to 90. In this case, when we took this snapshot, 88. And again, this rolls out quickly in really under 90 days. But again, it's all about the members. It's all about the member stories. It's all about how those members react to Wider Circle. It's how those members thrive in Wider Circle. I want to share another quick member story with you. This is about Cecilia. Cecilia was a really good cook, and this is in our cohorts in Medicaid in Detroit. She was a really good cook, and she started cooking for her circle of new Wider Circle friends. And then they all started to get together to cook meals together. And then before you know it, they were cooking meals and starting to distribute them in the local community and making and building bigger bonds within that community. That's really what Wider Circle is about. And that's what we did in this case in a Medicaid community in inner city Detroit. I also wanted you to hear a little bit more from Yolanda. She's one of our Medicare members out in California.
Before I joined Wider Circle, I was home every day, just about, doing not much of anything, you know. Then we started doing activities, and then I got myself moving, and I got off the couch. We went to the boardwalk in Santa Cruz, dinners, lunches, you know, we had dancing here, and we just had a great time. One of my favorite activities that we've done is exercises. Leg raises. We also do leg lifts, stretches for our arms, and then up. Wider Circle is so special to me. I just absolutely loved it.
Don't take my word for it, take Yolanda's word for it. So just to maybe recap a little bit here, by leveraging claims data, we're able to drive desired outcomes, drive desired behaviors, and drive actions in your members. We develop those lasting and meaningful relationships for your members. A consistent circle of friends and neighbors is built around them. Resources that make their life better, more sustainable, that give them the ability to have friends and neighbors that they can count on. We do this virtually, and most importantly, we do this in person. We actually get people together face to face, which is, you know, so unusual in this world of a myriad of applications. Our recurring meetings become part of the fabric of someone's life. It becomes part of their routine, and that consistency builds trust. It also gives health plans an opportunity to message other things to this dedicated audience. You know, health plans have many different channels they use, right? You use phone, you use text, you use your mobile application, your member portal. Well, Wider Circle is one additional channel that plans typically don't have until they meet us. And it's a channel, as you heard Claude say, can engage up to 22% of your members in our meetings. Having this singular channel where you can engage that many folks with one fell swoop is pretty special. Our facilitators are fully vetted, they're trained, background checked. Everything that we do is done publicly, out in the open, in restaurants and community rooms and in parks and museums. So it's all done publicly. And again, we help members achieve their health goals, address gap closures, social determinants are addressed on an ongoing and consistent basis. And maybe most of all is helping the member. But second most of all, we deliver a measurable and consistent ROI. We are attending, by the way, the AHIP conference next week in Baltimore. So if you are going to attend that, please stop by and say hello. We'll all be there. Dr. Pinnock will be actually speaking at that event as well. And with that, we're happy to open the floor up to any questions. You'll see there's an ability to chat those questions off to the right. Let's see. Claude, maybe I'll throw a few at you already here. Does it matter if Wider Circle is not currently in our geography?
Yeah, the short answer is no. So you may recall I discussed results from a 10-state dual national rollout. So we actually executed on that in a series of months. So as Bill mentioned, the usual rollout process takes about 60 to 90 days in a brand new state. And we have done it faster than that and on a far larger scale. So while it can help give folks confidence when we're already in their state, just know that we are able to roll out where you are if we're not already there, and do so very quickly. And the key is, as I always say, we're a people-first solution supported by best-in-class tech. As long as we hire the right people, we can deliver the results that we've shown there. So short answer, no.
All right, thank you. I see Elizabeth asked if the slide deck would be made available. And yes, it is, Elizabeth. You see my email on the screen. You see Dr. Pinnock's email on the screen. Feel free to just shoot us an email, give us a call. We'll be happy to share the deck with you. Let's see if we have another question here. Here we go. How do you, I'm sorry, do you do disease-specific cohorts? That's a great question for you.
Yeah. So the way as I sort of articulated earlier, we do these cohorts within the populations of focus, and they do often have a commonality, whether in the case of the example I gave, around maternal health or diabetes and things like that. It is important to our program that we engage the whole population, because what we're doing is also peppering in some positive deviants along with folks who are not necessarily performing as well as we would like them to. And they're really important for the sort of the psychology of influence in those group-based dynamics, in helping those members sort of adopt better health behaviors. But the short answer is yes. Bill, I think I have a question for you that's just come up here. This is definitely a Bill question. Are you a PMPM or PEMPM? I'm guessing that's per engaged member per month. What's your pricing model, essentially?
Sure. So, I mean, the pricing really depends on the specific engagement, whether it's, a small local engagement in a few different counties, whether it's statewide or national. In general, our model is a PMPM. It is different depending on whether the population is a Medicaid, D-SNP population, or Medicare population, because engagement rates are different, utilization of services are different. There is a small implementation fee that covers the cost of that first 90 days in standing up the program. And then, as I mentioned earlier, depending on the line of business, we typically build in a 25% bonus structure into the contract. So we're putting 25% of our revenue at risk based on certain metrics that are typically up to negotiation in the SOW process, but really take into account the plan's priorities. And it could be about retention or annual wellness visits or inpatient days. There's really a myriad of data points that we can use to create those bonus metrics and really show value. Let's see here. But maybe you want to dive in. I know I addressed it very, very lightly in the presentation, but how we deal with the more rural population. I think in the course of my talking about wider circle, people always, envision tons of people coming out to meetings in a very dense area. But how do we roll out a program like this in areas where there's less population density?
Yeah, it's interesting because when I joined the organization, I sort of assumed the same. So the first thing that's worth mentioning is we do have a virtual platform, and we do events virtually. So folks who aren't able to get out to an in-person event are able to still participate virtually. And this virtual platform has been designed to be extremely what I will call Luddite proof, like even I can work it with no issues. So it's very easy for our members to use and doesn't assume the ownership of a smartphone and fast internet access and all these sorts of things that folks often just take for granted as being something members would have. But the other thing, bizarrely, is we've actually found that rural attendance can often be higher than city-based attendance, even if folks have to drive a little bit. And the reasoning behind that is it's simply because there's generally fewer distractions. So we actually become more of an event, if you will, in those spaces, and we find that we get a nice catchment of individuals in rural populations. So a mixture of a bit of tech and also just the psychology of what's going on in those rural areas has meant that this has not really been an issue for our program. Bill, is there anything else you wanted me to add or you wanted to cover on that?
No, I think you covered it, Claude. I see one other question here, which maybe I'll take, which is about how this program benefits field agents and brokers. Um, this is something that can be obviously as a supplemental benefit. It is something that is incredibly saleable and attractive to members, right? Having this support system, having these groups to go to, and many of our customers um, that are in the Medicare space, create this as part of their benefit set, and that gets incorporated into their sales process, right? So this is something that is saleable to members, where it helps attract members to you as a broker and into your brand. And again, probably more importantly, even from a broker perspective, is that it helps you retain members, right? So your members are much less likely to attrit, move to another plan, move to another broker. They're much more likely to stay with that health plan because Wider Circle has given them a hug, because they have a destination on a weekly or monthly basis, because they have friends in our program to really keep them within the brand family where they are. So I would say that's really the benefit to brokers, is that your members are not going to move around as much when they are with Wider Circle, and Wider Circle is part of the benefits. And of course, that's a downstream benefit to the health plan itself. Needless to say, it's a lot more costly to bring on a new member than it is to keep the members you have. I believe that is our last question. I'll just give it another second, see if anybody else has any others. Not, I really want to thank everybody for joining us today and spending the past 50 something minutes with us. It's been a pleasure. As I mentioned, please feel free to email Dr. Pinnock or myself. We'll be happy to share the deck with you. We'll be happy to have a conversation offline, dive deeper into really any of the areas that we covered today. If you're attending AHIP next week, please feel free to stop by and say hello. We will both be there. And as I mentioned, Dr. Pinnock will be leading a session with a national health plan, as well as with one of our facilitators. So you'll actually get to meet somebody that's actually on the ground and doing the work, and hear what her experience is like. Claude, any final words?
If you're able to join AHIP in Baltimore, I look forward to seeing you, and thank you very much for your time. And you've got our details if you have any follow-up questions. Thank you so much.
I appreciate it. Have a wonderful afternoon.
Thank you. Thank you both for that great presentation and for sharing your thoughts. And we thank you, the audience, for participating in today's webinar. This concludes today's presentation. We thank you again, and enjoy the rest of your day.